IC&RC exam, codependency. Overly involved with the other person and that person's problematic behavior, takes on the role of caretaker sometimes to the other's detriment. Emotions get in the way and enabling results. Couples and family approaches. Treat substance users in the context of the family and social systems where use may develop or be maintained. Engaging the social system is a powerful predictor of change and may reduce attrition, gradually reducing using through sustained pressure of clients' social network, particularly with teens. The collaboration occurs when the clinical knowledge of the counselor combines with the experiential knowledge of the client because the client is the true expert in their life. The strength of the counseling relationship depends on the counselor's facilitation qualities, strategies used to create a positive environment for exploration and change. Purposes of clinical documentation. 1. Records, professional work, assessment, diagnosis, treatment, service planning, reviews and modifications. 2. Serves as a basis for organization and continuity of care, contains meaningful info, client response to treatment, key historical facts, ensures pertinent info is available. 3. Assists with risk management issues to protect against malpractice and professional discipline complaints. 4. Assure that record keeping meets the requirement by federal and state laws and licensing board, accreditation programs, third-party payers. 5. Facilitates quality assurance and utilization, documenting the appropriateness, clinical necessity, effectiveness of treatment, substantiating need for further assessment or treatment, improve quality of services. 6. Fosters communication and collaboration B/W team members. Under the privacy rule, clients have the right to 1. Receive a copy of their records. 2. Request to have mistakes corrected. 3. Receive notice on how their health info is used and shared. 4. Specify how and where they want to be contacted by service provider. 5. File a complaint if they feel their rights have been violated. Treatment modalities, levels. 1. Individual counseling, privacy, flexible pace, more time on individual unique issues. 2. Group counseling, most effective way of treating SUDS because they learn about themselves through interactions with others and understand that they are not alone in their problems. Clients bond with the culture of recovery and engage therapeutic forces. Peer confrontation, effective in treating depression, isolation, and shame. 3. Family counseling addresses systemic issues, harmful interaction patterns, assist families in understanding substance use disorders. Family can address their own goals and issue. Medication-assisted treatment, MAT. Evidence-based practices that combine pharmacological, drug-based, interventions with counseling, behavioral therapy, social support to achieve the best results in the shortest time. Medication can be used to manage withdrawal symptoms, reduce cravings, avoid relapse. Most meds require a script and supervision of DR. Primary treatment involves stabilization, meeting established outcomes, reduction of vulnerabilities, increase of resilience, recovery capital. Counselors must continually evaluate the client's level of risk regarding personal safety and relapse potential in order to anticipate and respond to crisis situations like high-risk situations. Successful treatment may require more than one treatment experience. Cumulative impact. Integrated treatment. Reflects the concern W/in SUD treatment progress for treating the whole person and recognizes the importance of ensuring that entry into any one system can provide access to all other needed systems. Motivational enhancement therapy, MET. Client-centered counseling approach to resolve ambivalence about engaging in treatment and stopping drug use. Evoke not guided change. Relapse prevention goal. Helping people to create positive habits and life changes in order to prevent relapse and sustain recovery. A crisis situation is a situation in which there is risk of harm to the client unless intervention occurs. Can be emotional or physical where client faces a problem that cannot be escaped without assistance. When integrated into comprehensive treatment programs, MATs can 1. Improve rate of treatment retention. 2. Decrease opioid and alcohol consumption 3. Increase abstinence 4. Decrease criminal activity 5. Increase employment 6. Improve mental health. The best way to handle a crisis situation is to prevent it. Common relapse triggers. 1. Unpleasant emotion 2. Interpersonal conflict 3. Social pressure. Meds for tobacco. Nicotine replacement therapy, bupropion, varenicline, Chantix. Features of modern-day treatment practices. 1. Focus on client competencies and strengths 2. Individualized client-centered treatment 3. Shift away from labeling addict, alcoholic 4. Acceptance of new broad range of treatment goals, i.e. reduction of use, improvement of health, employment stability 5. Adoption of recovery paradigm shift from problem-focused acute care model to solution-focused long-term model of recovery management regaining wholeness and connection to community 6. Integration of substance abuse treatment W/other disciplines, i.e. substance abuse treatment W/in criminal justice system, special services for those W/co-occurring disorders 7. Evidence-based practices proven to be successful through research methodology 8. Use of medication 9. Telehealth technologies, continuing care by mobile phone, online chat 10. Technology-based care multimedia, audio, video, facilitation relationships are characterized by 1. Empathy understand from another person's perspective 2. Genuineness when your outside matches your thoughts and feeling on the inside 3. Respect empowers the client. Belief that the client has the ability to make their own decisions and learn from the consequences 4. Self-disclosure ability to disclose info about oneself including the way one thinks and feels 5. Warmth showing client you care. Eye contact, smiling, sincere tone of voice 6. Immediacy focus on the here and now and on reality to keep the process moving forward 7. Concreteness ability to identify problems and steps to correct 8. Cultural sensitivity requires ongoing counsel or self-evaluation. Withdrawal management may be delivered 1. Ambulatory, outpatient, 2. Residential/inpatient, relapse. A setback that occurs during the behavior change process, such that progress toward maintenance of a behavior change goal is interrupted by a reversion back to the target behavior, best conceptualized as a dynamic ongoing process, rather than a discrete terminal event. All crisis prevention models are consistent with similar constructs of safety, stabilization, processing of crisis, drawing conclusions to be integrated as a learning experience. Special population considerations include co-occurring mental health/SEDS, criminal justice population, HIV, AIDS, physical and cognitive disabilities, women, pregnant women, older adults, adolescents. 3 components of the therapeutic alliance. 1. Relationship or bond B/W the therapist and client 2. Consensus B/W the 2 regarding treatment techniques/methods 3. Consensus B/W the 2 regarding treatment goals. HIPAA. Privacy protection for personal health information giving clients rights over their own health info, regardless of its form. Cognitive behavioral approach. A treatment approach that incorporates basic principles of learning to change the way people think. Operant conditioning. 1. Functional analysis relationship B/W stimuli and responses. Thoughts and feelings can contribute to maladaptive behavior. 2. Skills training learning process where behavior is modified by reinforcement or punishment. Individual recognizes high-risk situations and avoids them. 3. Strategies to cope when situations cannot be avoided. Definition of counseling. A professional relationship that empowers diverse individuals, families, and groups to accomplish mental health, wellness, education, and career goals. Cultural accommodation. Modifying the way a practice is delivered so it can be utilized with a particular culture or community. Electronic health records, heirs protecting the info. 1. Passwords, PIN numbers 2. Encryption 3. Audit trail that records who accessed info and what changes were made when. Successful implementation of EBPs include 1. Changes in professional behavior. Changes in organizational structure in order to support changes in professor behavior. 3. Changes in relationships. Cultural adaptation. Reviewing and changing the structure of the practice to more appropriately fit the needs and preferences of a particular cultural group or community. Implementation failure of EBP occurs when fidelity does not occur. Fidelity checklist. Documentation. Provides the means of organizing and evaluating clinical work by demonstrating that the services delivered are both effective and efficient. It is a tool in assuring continuity of care. Primary means professionals use to communicate about client care, serves legal and administrative purposes, used to support billing, proves that treatment staff were properly credentialed, verifies client consent, tool for counselor supervision, proof of competence. Addiction treatment drugs. Naltrexone, Vivitrol, opiate antagonist. Prevent effects, decreases desire to use. Helps relieve cravings for alcohol disulfiram, antabuse, bad reaction to alcohol acamprosate, Campril, reduces desire to drink methadone narcotic, synthetic opioid suppresses withdrawal symptoms of heroin and reduces cravings buprenorphine, Subutex, Suboxone contains naltrexone, helps prevent withdrawal symptoms. The goal of EBP is to integrate clinical expertise, scientific evidence, client values to provide high-quality services reflecting the interests, values, needs, choices of people served. HIV/AIDS. Injection drug users represent the largest HIV-infected substance abusing population. Relatively closed sexual networks. Sudden HIV is so interrelated, so treatment plays an important role in helping reduce risk-taking behavior. 3 legacies of AA. 1. Recovery, Big Book, 12-step work. 2. Unity, 12 traditions. 3. Services, every act toward the functions of AA message to others. Active listening skills. 1. Clear listening without judgment or trying to correct client thoughts. 2. Reflecting, summarizing using statements in clear simple manner to clarify the issues. 3. Ask open-ended questions to promote exploration of why client thinks, feels, acts the way they do. 4. Using effective body language, arms and legs uncrossed, leaning forward, making eye contact shows interest. 5. Watching for nonverbal cues, i.e. foot tapping. AA and other self-help is not for everyone, but helps develop a social support network, teaches skills needed to recover, helps individual take responsibility for their own recovery, and provides a sense of belonging and a new identity. The connection between the client and the counselor is the therapeutic alliance. Counselor skill include knowing how to individualize treatment plans, adapt counseling strategies to client characteristics and circumstances, apply culturally and linguistically responsive communication skills and practices. Areas of expectation counselor should address with client. 1. Outcomes achieved. 2. What proportion of clients report that their initial problems have improved by the end of treatment? 3. What will treatment involve? i.e. making regular appointments, enforcing start and end times, maintaining confidentiality, canceling session if client shows up under the influence. 4. What specific goals should the client expect to aim for? Factors associated with clients staying in treatment. 1. Motivation to change. 2. Family support. 3. Pressure from criminal justice system. 4. CPS. 5. Employers. Alcohol meds. Naltrexone reduces craving. Acamprosate reduce protracted withdrawal symptoms such as sleeplessness, anxiety, restlessness. Dysphoria. Disulfiram affects the degradation of alcohol, making user sick. The counselor must continually evaluate, assess, and respond to the client's status to ensure personal safety, help to prevent or address relapse, and anticipate and address crisis intervention as needed. A crisis as an event has 5 components. 1. Stressful or traumatic event. 2. A vulnerable or unbalanced state. 3. A precipitating factor. 4. An active crisis state based on the person's perception. 5. The resolution of the crisis. Enabling. When the codependent person unintentionally helped the person with SUD continue their problematic behaviors by repeatedly putting out fires for the addicted person, allowing the cycle of addiction to perpetuate. Al-Anon. Over 80% of positive treatment outcomes may be due to the therapeutic relationships contributing elements of warmth, empathy, and respect for the client. Meds for opioids. Methadone, buprenorphine, naltrexone. Key points about relapse. 1. Relapse is common following treatment. Talking about vulnerability to relapse, however, does not give permission to. Relapse is reasonably predictable. Clients should understand general precipitants as well as personal triggers, emotional danger zones, HALT, social situation, rehearse strategy, personal emotions and situations which should be anticipated and discussed with counselor. 3. Relapse is preventable. Self-monitoring and maintenance. Abstinence activities. AA, individual counseling, involvement in recovery community, i.e. lifestyle that is inconsistent with substance abuse, church, health club. Recovery consists of the following components. 1. Abstinence and symptom reduction. 2. Improved psychological and physical health. 3. Better social relationships. Restore damaged relationships and build supportive recovery community. Counselors help clients to 1. Explore and enhance their motivation to chance behavior. 2. Set appropriate treatment goals. 3. Understand the structure, expectations, purpose, and limitations of the counseling process. The client file is the official legal record of the treatment process and is subject to numerous legal and administrative requirements and clinical practice standards. Primary goals of trauma-specific services. Address directly the impact of trauma on people's lives and facilitate recovery and healing, are sensitive and responsive to unique needs of trauma survivors. Cognitive behavioral approaches and relational treatment while emphasizing safety and mental, physical and spiritual health. Verbal strategies. Focus on prevention and de-escalating. Non-physical verbal de-escalation is aimed at meeting the agitated person's immediate needs and calming the situation. 5 group models. 1. Psychoeducational, educate about substance abuse. 2. Skills development group, cultivate skills to sustain abstinence, cope with anger or urges. 3. Cognitive behavioral groups, alter thoughts and actions. 4. Support groups, pragmatic info, managing day-to-day living. 5. Interpersonal process group, older adults. 1 in 5 older adults have one or more mental health and substance use conditions and typically occur with other health problems. Age alters the way people metabolize alcohol and drugs. Losses may trigger or worsen depression. Complications arise. Determining the difference. B/W depression and grief and also cognitive, functional, and sensory impairments complicate detection of SUD or MH conditions. The effectiveness of addiction treatment is measured by clients' improved functioning, reduced suffering, physiological indicators, retention in treatment, enhances interactions with other people, work performance. The Spirit of Me is based on 4 key elements. 1. Partnership/collaboration, avoid the expert role. 2. Acceptance/autonomy, respecting and accepting the client's autonomy, potentials, strengths, perspectives. For aspects of acceptance: worth, empathy, autonomy, affirmation. 3. Compassion, keeping client's best interest in mind. 4. Evocation, the best ideas come from the client. The motivation for change is within. So discussion of pro and cons of change versus staying the same. Criminal justice population. SUD treatment reduces crime. Legal incentives may motive or are part of a repetitive cycle of long-standing patterns: poor coping skills, criminal value, lack of education, minimal job skills, history of trauma and physical/sexual abuse, women in particular. Screening for abuse history should be conducted. A coordinated response to ensure that offenders' needs are addressed while protecting public safety requires leaders in criminal justice and treatment system to share goals and systems of care. Examples of EBPs. Seeking safety, me, 12-step facilitation, CBT, DBT, community reinforcement approach with vouchers. 2 relapse prevention methods. 1. Relapse prevention therapy, RPT, behavioral self-control program that teaches how to anticipate and cope with relapse potential. Standalone or aftercare program focused on understanding of relapse process, identify and cope with high-risk situations and emotions, urges and cravings, staying engaged, creating a balanced lifestyle. Cognitive techniques help reframe habit change and behavioral techniques include lifestyle modifications too. Senap's model of relapse prevention therapy method to prevent clients from returning to substance use after treatment, integrates AA and counseling, believes abstinence, EFE-style changes, personality changes is essential. Process-oriented interaction B/W client, counselor, group. Within an agency, information can be shared on a need-to-know basis. Must be part of the treatment team for access, for example, counselor to supervisor or program physician. 5 components of CMRPT. 1. Assessment 2. Warning signs identification 3. Warning sign management 4. Recovery planning 5. Relapse early intervention training. Strategies aiming to help clients manage their own behavior. Stress and anger management groups. Pregnant women. The younger the mother, the more use. Substance abuse often creates an array of social problems including violence, child abuse or neglect, and family dysfunction. A stressful event alone does not constitute a crisis, rather. Crisis is determined by the client's view of the event, encompassing their personality, life experiences, coping skills, degrees of stress and their response to it. Crisis can result in deterioration or growth. Examples of therapeutic approaches: behavioral, cognitive, motivational, family, couples approaches. Family counseling has 2 main purposes. Use family strengths and resources to find ways to live without substances of abuse to improve the impact of addiction on the client and family. Issues about HIV and SUD treatment. 1. SUD treatment serves as HIV prevention too. HIV, SUDS, MHD interact in a complex fashion. Each acts as a potential catalyst or obstacle of the other two. Legal issues arise when treating SUD and HIV. 3 treatment goals: living substance-free, slowing or halting progression of HIV, reducing risky behavior. 4 treating HIV is complex and care should be integrated. 5 individual with HIV and SUD are subject to higher rates of mental health issues. 6 counseling is important to maintain health, achieve recovery of SUD, attain best possible level of psychological functioning. 7 risk reduction promoting change in substance-related and sex-related behaviors. 8 reduce the spread of other blood-borne infections. 9 counselors should be familiar federal and state laws protecting HIV, AIDS-related info. Family treatment models. Brief strategic family therapy, structural/strategic family therapy, multidimensional family therapy, multisystematic therapy, behavioral and cognitive family therapy, solution-focused brief therapy. Motivational style of counseling communication is based on the following assumptions. 1. Ambivalence about change is normal and creates a significant obstacle to the recovery process. 2. Ambivalence can be resolved by working with the client's intrinsic motivations and values. 3. The alliance B/W counselor and client is a collaborative partnership to which each brings important expertise. 4. An empathetic, supportive yet directive counseling style provides conditions under which change can occur. 5. Direct argument and confront ion may tend to increase client defensiveness and reduce the likelihood of behavioral change. Measuring client progress. Many programs have prescribed pre- and post-test measures. Abstinence is not a sufficient indicator and should document improved functioning in multiple domains. Models of addiction. 1. Medical model: chronic and progressive disease with physical causes. 2. Spiritual model: very influential. 12-step fellowships. 3. Psychological model: deficits in learning, emotional dysfunction, or psychopathology that can be treated behaviorally. 4. Sociocultural model: building new social and family relations and skills and working in one's cultural infrastructure are avenues for change. 5. Composite biopsychosocial spiritual model confirms some truth in each model and integrates the perspectives B/C of many interacting influences. Chronic diseases are best treated collaboratively and comprehensively. Non-traditional self-help groups. Rational recovery, women for sobriety. AA main purpose. Stay sober and help other alcoholics to achieve sobriety. Belief that abstinence is the only treatment. Recovery is shifting from acute crisis-orientated care to recovery management, providing long-term supports that are wellness-centered, including ongoing growth, self-discovery, and creating a new identity that does not include substances. Co-occurring disorders. Address interrelationship of the two disorders and adapt traditional treatment. It is when a diagnosis of SUD and co-occurring mental disorder can be established independent of one another. Issues impacting women with SUD. 1. Shame and guilt. 2. Physical/sexual abuse. 3. Relationship issues, fear of losing partner, children, needing permission to go into treatment. 4. Treatment issues, lack of services and childcare, long waiting list. 5. Systematic issues, lack of financial resources, sober living, housing, or poorly coordinated services. Counseling is a co-laborative process sensitive to individual client characteristics, influence of significant others, and client cultural and social context. Lapses. Indicate the need to readjust treatment. 5 general principles of me. 1. Express empathy through reflective or active listening. 2. Develop discrepancy B/W client's goals or values and their current behavior. 3. Avoid argument and confrontation. 4. Adjust to client resistance rather than oppose it directly. 5. Support self-efficacy and optimism. Functions counselors may perform with recovery plans. 1. Formulating recovery goals. 2. Identifying objectives to help meet recovery goals. 3. Facilitating linkages for support services. 4. Establishing marker to measure progress. 5. Monitoring client progress and providing support. 6. Creating emergency backup plans when things do not go as planned. Most researchers consider relapse to be a complex process and not viewed as a negative endpoint but as a transitional process from lapse, reoccurrence of use, to relapse. Lapses are thought to relapses are thought to be part of the learning process that eventually leads to recovery. Recovery management involves reduction/elimination of symptoms, improvement of wellness, improvement of health, rebuilding community life. Strategies based on 5 principles. 1. Ask open-ended questions to facilitate dialogue in a neutral way. 2. Listen reflectively and provide a synthesis of content and process, which reduces the likelihood of resistance and cements the therapeutic alliance. 3. Summarize to link the client's positive and negative feelings to promote the perception of discrepancy. 4. Affirm to promote self-efficacy and validate client's feelings. 5. Elicit self-motivational statements that include problem recognition, concern about the problem, intention to change, optimism toward the future. Peer recovery support. Links professional and natural non-clinical support networks. Can be used before or after treatment or instead of. Contingency management therapy. Patients earn vouchers for negative drug tests, motivational incentives, physical and cognitive disabilities. More likely to have a SUD and less likely to get effective treatment for it. They are more likely to use substances B/C of homelessness, unemployment, social isolation, lack of recreational opportunities, victimization. Typically better to integrate into treatment with some exceptions, i.e. DEF. Key features of 12-step groups. Accessibility, anonymity, social support and aid, promotion of self-esteem and self-efficacy, introspection and insight, spiritual recovery, advocacy to promote social and legislative remedies. EVB. Is supported by scientific evidence that proves they work to produce specific outcomes. Withdrawal management involves 3 components. 1. Evaluation drug testing. 2. Stabilization medically stable, fully supported, substance-free, maybe medication-assisted. 3. Fostering the client's entry into treatment, stressing the continuum of care. 2 examples along the residential care continuum. 1. Therapeutic community, TC, highly structured residential program to help change lifestyles, abstain, eliminate criminal behavior. Use a hierarchical model with treatment stages that reflect increased levels of individual and social responsibility. Peer influence, can be confrontational, last 6 most 2 years. Frequent modality used for persons in criminal justice systems who are getting addiction treatment too. Halfway house clients live at the program receiving counseling while they work or attend school. Cognitive behavioral therapy. Short-term focused approach helping individual with SUD become abstinent assumes that learning processes play a role in the development of SUDs. Feelings and behaviors are caused by a person's thoughts, not outside stimuli like people, events. The goal of CBT is to teach the client to recognize and avoid situations where they are likely to use. Motivational interviewing, me. A directive, client-centered style for eliciting behavior change by helping clients explore and resolve ambivalence. The fuel for the CHAMPS process is the client's motivation to make the change. Can enhance motivation starting at the screening and lasting through the treatment process. AA. Ongoing recovery support through self-help. Women. Men use more illicit drugs, women more prescription, 48% more likely. They abuse different drugs and the effects are different for them. Women progress faster than men from initial use to consequences, telescoping, using to self-medicate for anxiety and depression, more likely to have multiple comorbidities. Women are more relational. Substance abuse equals disconnection. Repairing connections is critical. Family-centered treatment to improve family functioning. Steps in crisis intervention. 1. Assess severity. 2. Form a connection. 3. Explore problem. Focus on immediate situation with emphasis on the present/immediate past with the goal of restoring the person to their previous level of functioning. Tools used are active listening and paraphrasing. 4. Deal with feelings and emotions to form a complete picture. 5. Generate alternative solutions. Summarize to discuss alternative possible solutions. 6. Develop action plan, specific, concrete follow-up plan with time,